Welcome to the American Indian and Alaska Native Behavioral Health webinar series presented by the National American Indian and Alaska Native Addiction Technology Transfer Center. I'm Kate Trams and I will be administering today's webinar. Today, Dr. Barbara S. McCready will be presenting Cognitive Behavior Therapy for Substance Use Disorders. This training series is brought to you by the National American Indian and Alaska Native Technology Transfer Center, or ATTC. The National American Indian and Alaska Native ATTC is one of 4 national focus centers which serves the ATTC network. The ATTC network is a nationwide network made up of 10 regional centers, 4 national focus centers, and a network coordinating office. The map on this slide shows the location of the 4 national focus center ATTCs. To learn more about our center, the network, or your regional center, please visit our website. Our next webinar in this series is scheduled for Wednesday, May 7th, when Wendy O. Kalberg will present Overview of Fetal Alcohol Spectrum Disorders, What We Are Learning About Diagnosis and Intervention. We also offer the Essential Substance Abuse Skills webinar series each month. The next session in this series will be held on April 16th, when Denise Casillas will present Clinical Evaluation Assessment. For more information on our webinar series, you can contact me at the email address or phone number provided on this slide. Our center is a NADAC certified educational provider, and we'd be happy to provide you with CEHs. The cost is $10 to do so. The CEH request form is available for download in the Files pod in the webinar screen. If you choose to download a file, a new tab will be opened in your browser, and you will have to click on the webinar window to return to view the webinar. If you are unable to download the documents from the webinar, please contact me using the information on this slide. Immediately following today's webinar, you'll be redirected to our GIPRA evaluation. We invite you to participate in this brief online customer survey. This survey asks about your satisfaction with the event and will take less than 10 minutes to complete. GIPRA stands for the Government Performance and Results Act, and SAMHSA asks us to evaluate our events in order to comply with this act and to provide improved performance assessment and accountability. SAMHSA uses information collected by these surveys to determine how many people have attended our events, your satisfaction with our events, and how useful our events are to you. We hope you will assist us in gathering information about our services by participating in our survey. Before we start today's session, I'd like to go over a few instructions for the Adobe Connect system. To view the presentation in full screen mode, click on the full screen button, which may look like 4 arrows pointing outward, at the top right corner of the presentation pod. To return to the regular view, click the button again. You will be muted for the duration of this webinar. Please use the Q&A pod to share your questions and comments. Your questions will be visible to myself and the presenter, and we will moderate them as they come along, but we will save question and answer time for the end of the presentation. We would also like you to be aware that this webinar records participant attention time. If you minimize the webinar or are working in another window, the system will record your participation as inactive, which may be reflected in the number of CEHs received. The opinions expressed in this presentation are those of the presenter and do not necessarily reflect the official position of CSAT, SAMHSA, or the U.S. Department of Health and Human Services. Today's webinar is presented by Dr. Barbara S. McCready. Dr. McCready is a distinguished professor of psychology and is the director of the Center on Alcoholism, Substance Abuse, and Addictions at the University of New Mexico. It's needless to say that she is an expert in this field. She's been working for a number of years in substance abuse and has been published numerous times and has done a great deal of research in this area. And so we want to welcome her at this time and just thank her so much for joining us and sharing her expertise on this subject.
Okay, so over to me, Kate.
That's you. Thank you so much, Dr. McCready.
Great. Thank you so much. And thank you all for participating in this webinar. And I appreciate the invitation from the ATTC to be able to participate. Oh, my clip art is covering up things in this talk, which wasn't happening before. I hope that'll be okay. I'll try to, if things are covered up, I'll let you know what they are saying. Okay. This morning, in the next 45 minutes, I'm going to try to do four things really. First is to give you all an overview of the cognitive behavior therapy model for conceptualizing drinking and drug use problems. Within that model, I will be integrating unique aspects of CBT with American Indian, Alaskan Native clients. Everything I'll be talking about this morning has a research base for it. Unfortunately, there's virtually no research on ways to adapt CBT for American Indian or Alaskan Native populations. So the information that I've integrated here is based on just the little bit of research that's out there. So I'll be interested if we have any time to talk about this at the end, about others' ideas about ways that this approach might be modified further. The core of the CBT approach is what's called functional analysis, and I will be showing, using a specific American Indian client that we've treated here at the University of New Mexico, obviously identifying information changed about this individual, but I'll be using a specific client to illustrate some of the aspects of case conceptualization and treatment planning. The last part of the slideshow includes a number of treatment tools. I may or may not go through all of those depending on the time, but they're there for you to use if you want to. There's some handouts and worksheets and things like that. Okay. Cognitive behavior therapy is an approach to alcohol and drug treatment that's been around really since the 1970s. There are a number of good treatment manuals that have been published, some by the federal government and some that have been published privately, and I've just show several of those here for any of you who are interested in learning more or finding a specific treatment manual that might be helpful to you. I looked at Kate sent me the list of potential participants in this webinar, and I saw that about 2/3 of you are working actively in the substance abuse treatment field, and then most of the others seem to be working in mental health. So I'm guessing that most of you have some familiarity with cognitive behavior therapy. But I wanted to provide a little bit of an overview first, just some introductory kind of thoughts about CBT. First, CBT gives a framework to conceptualize alcohol and drug problems. It's not the only framework out there, but it's one that I find useful as a way to think about a person's drinking or drug use, the context in which it occurs, and to provide really a roadmap for recovery, for developing a treatment plan for a person. In addition to the framework, CBT also provides a set of techniques that help people change. Those techniques have been used across a number of different kinds of treatment models. I know, for example, that the Hazelden Foundation in Minnesota, which provides very much 12-step oriented treatment, does a lot of social skills training as part of their treatment program. That's a CBT technique. The framework is fairly well-defined, but the content of the treatment is always individualized, and it's adapted to the individual's needs and the cultural context in which they live and work. So although you'll see, and what I'll be trying to do today is to show you some of the ways to include cultural content within the CBT framework. And then finally, I want to emphasize that CBT sometimes gets mischaracterized as a more mechanistic or kind of dictatorial sort of approach to treatment in which people tell the client what to do. And that's really a mischaracterization. Most CBT is offered in a very client-centered kind of orientation. The general spirit of motivational interviewing really infuses CBT, even though it's a much more structured approach. But the idea of meeting the client where they are, working with them, showing them respect, is really central to a cognitive behavioral approach. And I wanted to emphasize that because, as I said, sometimes people think of it as somewhat more mechanistic and it's really not. Okay, there are some basic assumptions about alcohol and drug problems that are underlying the cognitive behavior therapy model, and I'm going to go through some of those in the next several slides. The first is that although historical factors, I think, are often very important to understanding how or why someone has developed a drinking problem, they are not the major focus of the treatment. That doesn't mean as a therapist that I would ignore historical factors or dismiss them as clients talk about things that are important to them from their history or the history of their people. But that in being able to help somebody change, I really like to focus on the person's current situation. What are the things that are helping to maintain their drinking or drug problem? What are the resources that they have that may help them to change? Historical factors typically affect people in the present as well. And so to the degree to which that's the case, they become an important part of the treatment. But it's really the historical factors affecting a person in the present. Another really important assumption of CBT is that drinking and drug use really occurs in the context of multiple systems. Some of those factors are individual and within the person, but much of what maintains a person's drinking is also integrally involved with both their family and the other social systems and social contexts in which they're living. And that's, as you'll see in the next slide, we use a kind of an organizing model. We call it functional analysis. And as we think about functional analysis, we really look at, where's my arrow? Here it is. Okay. We think about drinking or drug use as occurring in, and this one is a line, you'll see the next one, which is a little bit different, but that something happens within a person's environment. We call it a trigger. And a trigger can be anything that increases the chances the person feels like drinking or using drugs. The trigger might be an emotional situation. It might be something that happens in a relationship with somebody else. It might be just a specific location or a time of the day or a day of the week. We assume that triggers do lead to reactions within an individual, thoughts and feelings about the trigger and about drinking itself or drug use. Those thoughts and feelings then lead to the behavior of drinking or drug use. We also assume, and I'll come back to this in a little bit more detail, that drinking and drug use is maintained by the good things or the positive consequences that occur after the use. And those things are usually fairly immediate, and those are the reason, often part of the reason, many of the reasons why people continue to use. Of course, the negative consequences are what motivate people to change. And these, unfortunately, are often delayed, and so they're not as motivating initially for a person in terms of changing their behavior. I also, though, often think of functional analysis or a behavior chain as a circle rather than a chain. And as you think about it, something happens in the environment, a person reacts, they drink or use drugs, good things happen, bad things happen, but often those negative consequences then become triggers for the next episode of use. And I'll come back to this in a little while to show you with the client that I'm going to use as my illustration throughout the presentation. I would like to go back into the CBT model and talk a little bit in more detail about each of these components of the model. So triggers, as I said, are events or situations that occur before drinking or drug use, and they increase an individual's desire to drink. Some clients don't like the word triggers because they think it's sort of like a gun going off, that if this thing happens, it's automatic that they're going to use. So some people like the term high-risk situations rather than the term triggers. Triggers is easier, which is why I usually use it. But the important thing is that when something happens in the environment, it doesn't mean that the person will use. It means that they're at greater risk, and that the more, as a person learns, as a client learns much more about their triggers and the things that place them at risk, it puts them in a position where they can change those, or they can be ready for them, or they can know how to get help or support at times when those things are going to occur. So it's the importance of triggers is to be able to identify what are the things that make it hardest for a person to not use in a particular situation. As I said, triggers may be individual, they may be related to family, they may be related to other social relationships or other events within a community. The internal reactions are important, and for many clients, understanding how they're reacting to triggers becomes a really important part of helping them just understand their alcohol or their drug use. So if a situation happens, and I'll use a really simple example here, a person has a job, and at the end of the day, they're in a carpool, and the carpool always stops at a bar on the way home. So a very simple trigger, you're in the carpool, you're pulling up to the bar. As a person is trying to change, as they start to think about that situation, they may have some actually experience craving because they're anticipating being able to drink, and that would be a physical reaction. If they're trying not to drink, they may also have emotional reactions, like this is a very uncomfortable situation to be in your carpool, and maybe you don't have a car, so you have to go with the carpool. So you feel anxious and uncomfortable because you don't want to drink, but here you are at the bar with your carpool friends that you've been drinking with for a number of years. You may have self-evaluative reactions to that situation, saying, you know, I'm such an idiot, why am I reacting this way? I know that I don't want to drink now, so why do I even feel like wanting to drink? So any kind of a trigger may elicit a variety of internal reactions, physical, emotional, and self-evaluative. And then sometimes in there, a person is thinking about the good parts of alcohol or drugs. So that person walking into the bar with their friends may start thinking, you know, it'd really be it's always a lot of fun to hang out and have a couple of beers, and it really won't hurt my sobriety too much. You'll notice that my clip art for this slide is a tumbleweed, and I selected that because I think often people's thoughts and feelings are quite a bit of a tumble as they're trying to deal with these situations. There is a little bit of research that suggests that in a CBT approach that American Indian or Alaska Native clients find a deep focus on thoughts and feelings perhaps less helpful than some of the other aspects of CBT. So I did want to mention that, although it is a part of the model that is important to at least pay attention to. But if you have a client that is really not focused on introspection and thinking about, oh, what am I thinking in this situation, what am I feeling, it's not necessary to keep focusing on that in depth. If you think about the behavior chain or the behavior circle, functional analysis circles that I showed you, the next step is the consequences. And here I have a nice little prickly barrel cactus, because consequences are the sort of prickly part of drinking and drug use. We do assume that there are positive consequences. Those may be physical, as in decreasing withdrawal. They may be cognitive, in the person thinking differently about a situation or themselves. They may be emotional. A person feels less upset or less depressed. Or the consequences may be environmental, in the sense, the positive ones, in the sense that people around the person are supporting them in drinking or drug use, and their social group or their family or their community is a very substance-using community. So those can all be positive consequences. And there are obviously many positive consequences that come from a person's social network. As I mentioned, the positive consequences come before the negative, and the negative are really what drive change. Okay, this is the client that I'm going to talk about on and off during the rest of the webinar. I'm calling him Daniel for the purposes of the webinar. He was a Native American young man in his 20s who came to our clinic. He was trained as a pipe fitter, but he had not been working for a while. He was he did not live on the reservation. He actually never had. He lived with his mother in a community just across the river from Albuquerque. To show you how one puts together a functional analysis, I've put down 4 different situations that Daniel had talked about in the course of the treatment. The first was, as I said, he lived with his mom, and his mom did not like it that he was not working, and she nagged him often. His reactions, the thoughts and feelings part, grab my arrow again here. Sorry. For some reason my arrow is not moving for me. I don't know if Kate can help me.
What happens with the arrow is it'll just show up wherever you click, Dr. McCready. So
Okay.
wherever you want it to be, you'll just have to click there.
Okay, good. It's nice having technical support. Okay, so the Daniel's reactions when his mom would nag him to get a job, he felt very ashamed. He felt he wasn't really doing what he should be in his life, and ashamed that he wasn't able to work. But he also didn't feel like he was ready to work because his drinking was really quite severe. He was a daily drinker, drank a lot when he drank, and was physically dependent. And he just didn't think that he was ready to have a job. And so he would also feel angry at her for nagging him. Oftentimes it would lead him to decide to drink. And the best thing from his point of view about drinking when his mom was nagging him was that he then felt he could kind of ignore her. He could just tune her out. But of course the consequences were pretty significant for him. By continuing to drink, he still wasn't ready to work. His mother was mad. His brother was also very critical of him. And his brother lived on his own with his girlfriend in an apartment fairly nearby. And he would really get angry at Daniel for living with his mom without working and that kind of thing. And so when Daniel would drink, often his brother would get more critical of him, and that just added to the cycle. Daniel was a guy without a car, and he rode his bike everywhere, and there are a lot of liquor stores in his town. So a second trigger for him was when he would ride his bike toward or by a liquor store. And we talked with him about what would happen even when he was trying not to drink. And his first thing was, I'd think, well, I'll just get a 4-pack. I won't really drink a lot. There are a lot of guys that hang out there that I really like and I like to spend time with. So it's kind of appealing, and so I drink. In that situation, very different kinds of positive consequences. He liked the taste of beer. If he had any withdrawal symptoms or withdrawal symptoms might be coming, he didn't experience them because he kept drinking. And this was one of the situations where he liked to hang out with people, and he felt that it was, desirable consequences. Again, however, the negative consequences, he'd get very down on himself and say, I'm wasting my life. And I'm not really hanging out with positive people. I'm hanging out with other people who he saw as losers like him. A third trigger for him, because as I mentioned, Daniel was very physically dependent on alcohol. So if he didn't have a drink for 4 hours, that in itself would be a trigger. So just time between drinks would be a trigger for him. He would start to experience some physical symptoms. He'd be starting to shake. He had withdrawal seizures in the past, and he was afraid as he would begin to develop withdrawal symptoms, he would be afraid he was going to have a seizure. And then he would experience a strong craving to drink. He would drink in response to this, and the physical consequences were very positive. The tremors would go away, and he would feel secure that he wasn't going to have a seizure. Of course, he was still addicted. This was his own view of what was bad about that. His mom would be angry, and the shame and embarrassment would continue. Finally, as a fourth example, because Daniel wasn't working, he would often be home alone. He'd have nothing to do from his point of view. He would feel depressed and bored. He would drink. And mostly what that would do in terms of positive consequences would have just helped him forget about his problems. At least he thought it did. He would still be depressed, and he would continue to feel that he was letting everybody down. So these 4 triggers, mom nagging, riding a bike, haven't had a drink for several hours, and being home alone, really show you the kind of range of things that we can think about as triggers. Everything from interpersonal to environmental to simply really time and physiology. So there are a lot of different kinds of triggers and very different kinds of reactions as well. As I mentioned before, we can also think about functional analysis as a circle, and I just took one of these to show you an example. So Daniel would ride his bike to the liquor store. He would get a 6-pack. He would drink, or 4-pack, sorry. He would drink. He would enjoy it for the moment. He would get really down on himself. And then these negative consequences, the feeling that that he was wasting his life, that he wasn't hanging out with positive people, would then serve as a trigger. And it might be a different trigger. This in itself could be a trigger that would lead him to decide, okay, I'm just going to go 6-pack. I'm going to find people to hang out with that I like hanging out with. So drinking, even though I often show it as a straight line, it's really not, because the consequences often set up people for the next trigger. And that's why thinking about it as a circle is often really helpful, both as a therapist and as for clients. To get started with treatment, as with any treatment, a CBT therapist is going to start by trying to establish good rapport with the client, and that obviously involves listening to them, trying to understand what their concerns are, using reflective listening, rolling with resistance if the client is ambivalent about being in treatment or about trying to change. And so that process of establishing rapport is really what characterizes, I think, any kind of good therapy, and is absolutely characteristic of CBT. A second important part of getting started is doing a good assessment to understand the client's concerns, the ones that they're presenting, as well as a good alcohol and drug assessment and mental health assessment, and understanding the life context in terms of their work, family, and community, to understand what are their strengths, what are the strengths in their community that may help them to change, and to understand how those things are interwoven with their alcohol or their drug use. The third piece of getting started is really developing that CBT conceptualization of what's maintaining the drinking or the drug problem. That's developing those behavior chains or those functional analyses. I do this very carefully with the client. I don't say, here's what's wrong, but rather saying, a way that I find really helpful to understand a person's drinking or drug use is to understand what's going on in their environment, how they think about it, and what are the good and bad things that are happening. I'll often do a single behavior chain with a client to show them how to do this, or single functional analysis. And then there's the sharing and inviting in their perspective. So here's how I'm thinking about your drinking. How do you think about it? I think, from what you've told me, I'm thinking that there are a variety of things that happen that are upsetting to you, that lead you to want to drink. You also seem to have a group of people in your family and your community and your friends that are heavy drinkers. And it seems to me that's part of what's keeping your drinking going. It also seems that you maybe don't have a lot of positives in your life that aren't related to alcohol or drug use. So I present that to a person and then say, what do you think? How do you think about your drinking, your drug problem? And what are the things that you think are keeping it going? So we come together around that. And if a client is bringing in a number of other additional perspectives, then I try to weave that into the therapy as much as I can. My sort of model is I don't ever disagree with clients. I don't say that's wrong, but I may say, if a person is saying, well, I was sexually abused when I was a young child, and I think that's really the root of my drinking at this point. I may say something like, it sounds like that's something that's very important to you, that it's been very distressing to you. It'll be important to talk about how that affects you now, in the present, and how that's part of your life, and how you think that's difficult for you now. So I may partially redirect a person, but I won't ever say, oh, no, that's not part of it. Then the final part of really getting started is developing a treatment plan. And with all of my clients, but particularly with American Indian or Alaskan Native clients, that treatment plan really needs to involve the client's family and their community. Because we know that substance use occurs within a community context, and if we ignore that and just hope that the individual can both change themselves and then change their community, I think we usually don't do as well in treatment. And there actually is a lot of research that suggests involving the family leads to better treatment outcomes. So it makes a lot of sense. In developing a treatment plan, a cognitive behavioral treatment plan, it's useful to use multiple sources of information. Obviously, interviewing and talking with the client is important. With many clients, I like to use questionnaires to supplement the information I ask for in a questionnaire, in the interview. I use self-recording cards, which I'll show you in a couple of minutes, to help a person learn how to kind of keep track and be more aware of what's going on with their substance use. And I often like to have a family member or members come in early to help kind of flesh out the context of a person's life and their drinking or their drug use. A second thing that I always do with clients is to develop a sobriety plan. So, we often have clients who come into treatment who are actively drinking or using drugs at the time they enter treatment. And we need to have a deliberate plan to help them get from being intoxicated and using to being abstinent or sober. And so with different kinds of drugs, there are different plans, but it's really a crucial part of it. I actually didn't put on this slide, but I also always evaluate a person's physical or medical status to see if they have any acute medical problems, because we know with so many of our alcohol and drug users that they have really significant medical consequences from their use, or they have health problems that they've simply not been paying attention to because they've been using. And so I always like to find out what a person's health status is, what kinds of health problems they have, and where possible, then if they need medical care, to make a referral so that they can get that as well. And then finally, I assume that everybody comes into treatment with some degree of ambivalence. Some people have a strong desire to change, and they totally are at the point where they say, my drinking or my drug use is so bad, I have no place to go except to change, and I have to do that. But even with them, there have been reasons why people have used. There have been those positive consequences, and as a person enters sobriety and gets into it, sometimes they miss some of those positive aspects. So I'm always thinking about motivation and a client's motivation throughout the treatment, and paying attention to listening to what they're saying and listening to how they're thinking about using and not using. So depending on the client, as I mentioned, the functional analysis is a nice way to kind of integrate a lot of information about what's going on with a person. What are the situations? How are they thinking and feeling? When and where are they drinking or using drugs? What alternative kinds of coping skills do they have? What kinds of consequences are there? What's their social environment? I don't try to address all of those with every single client. Different clients, different parts of this are much more important. So depending on the client, I may focus on one or more parts of the functional analysis very differently. I'm going to spend a number of minutes here. I don't know if I can, well, I'm going to spend several minutes here talking about a treatment planning sheet that we developed for Daniel. And as I mentioned a minute ago, the sobriety plan becomes very important. And for a client who's physically dependent on alcohol or another drug, you really have to start there. So the challenge for Daniel was that he was drinking every day, and he's had seizures in the past when he would stop drinking. So the solution that we talked about, and I should just mention, each of these possible solutions is not something that I came up with, but these are things that Daniel and I, or actually it's not, Daniel was a client of one of my students, so I always feel like I'm treating clients even when I'm supervising, so I keep saying I, even though I was doing this through the student therapist. But anyway, with each of these parts of the treatment plan, these are things that we come up with together with the client. It's not the therapist dictating this is what you're going to do. With one exception, I will say this sobriety plan with a client who has this level of physical dependence, who's had seizures or has had major withdrawal symptoms in the past, the only safe way to stop drinking is to have a medically supervised detox, preferably in an inpatient setting. We have a public detox here in Albuquerque, and so we were able to talk with the client about going to the inpatient detox. Okay, so going through that behavior chain, thinking about high-risk situations. He's got a lot of them. His mother gets upset with him. He doesn't have a car. He doesn't know people who don't drink. He doesn't have a job. He hangs out at home a lot. I want to mention one of the things, I guess Kamala Venner, who's one of my colleagues here at CASA, is going to be doing a webinar in a couple of months. And one of the things that she always emphasizes is that when you look at survey data, it's clear that although alcohol problems are significant in American Indian, Alaska Native populations, this is also the population that has the highest rates of abstainers of any group. And many of our clients who are heavy drinkers don't know any non-drinkers, and they've bought into the cultural stereotype, that says everybody drinks and lots of people have drinking problems. Kamala has, I hope she doesn't mind my stealing her thunder, she said when she does workshops with American Indian clinicians, she sometimes asks, what proportion of American Indians do you think have drinking problems or drink? And she says, people usually say 90%. And what percent have drinking problems? Sometimes people say 40%. Those are both wrong. There are lots and lots, the rates of non-drinkers are actually, the rate is very, very high. And so it's an important part in my thinking about treatment plans with American Indian clients to help them to first know that there are a lot of non-drinkers out there, and to help them figure out how do I find these folks and how do I find this group to be my social group rather than my drinking group. A number of solutions that we came to with Daniel included, and this is a skill, a behavioral part, but learning just some different ways to talk to his mom. We also talked about having his mom come to the therapy. He did not like it that he wasn't working. He really didn't want to work as a pipe fitter and work on construction jobs because he thought that was really going to be high stress, but he thought he could probably find a lower stress job in order to have a way to be able to save some money. And then, as I mentioned a minute ago, we also talked about helping him find ways to meet people who are non-drinkers. And he had some really nice interests. He really liked to sculpt or carve wood fetishes, and he also played the guitar really quite beautifully. And he also did a lot of sketching that was quite really high level of talent. And so we began to talk with him about ways to find people to spend time with that were more, doing more positive things that were consistent with what his goals were to be a non-drinker. Daniel was a person who had some introspection about himself. He really did see himself as a person who was letting down his family and his community. He also, that's a cognition, he also wanted to drink because he was so afraid of the seizures. And then finally, he had a view of himself as a hopeless alcoholic. His father had a serious drinking problem. And so he was very, very resigned to believing that he had the same kind of hopeless and bad future. Part of helping him address some of these negative thoughts was to talk with him about what would help him feel that he was a positive part of his community and family, instead of feeling like he was a loser, somebody who was letting people down. And to help him think about what his values and goals were. What did he want to do? And also, even though his father was an alcoholic, his father had some really positive qualities, and so we wanted to help him be able to think about himself vis-a-vis his father somewhat differently. And then also to think about people in his community that he admired and respected, to think about how could he move toward trying to be more like those folks than the people that he saw were negative, that he was identifying with. Changing behavior, he did have a lot of challenges. His job skills were somewhat limited. He didn't know how. He really didn't at all know how to talk with his mom and brother when they were saying things that upset him. And as I said, although he had some real talents, he really didn't pursue them or really have much that was positive or meaningful in the way he was spending his time. So we talked about, once he got some sobriety, looking at some job training programs, as I mentioned, getting a basic job in the meantime, learning some communication skills, both for himself and by involving his mother and his brother in the treatment, and then considering ways that would be meaningful for him, both personally and culturally, and more positive as ways to spend his time rather than what he was doing when he entered treatment. Okay, and then finally, changing social environments became really important for him. He, as I said, he lived with his mom. He found that all stressful, very, very stressful. All the men he knew and hung out with were heavy drinkers. We began to talk with him about the possibility of AA, and he was pretty shy and felt really uncomfortable going to AA meetings alone. Some of the solutions that we worked towards with him included, as I've mentioned this several times, I'm sorry to be redundant, but it fits with different parts of the treatment plan. But involving his mom in treatment, working towards having a way to live either on his own or with other family members that he would feel more comfortable with, finding non-drinkers in his community. Also learning, finding someone to go with to AA meetings. He actually got involved in an intensive outpatient program as well as our weekly outpatient program. And his counselor there was a person in recovery who began to take him to AA meetings or would meet him at the meetings. And that it was a way to create a bridge so that he didn't have that discomfort and shame, feeling of shame about, like, I can't go there. Depending on the community, our community, because we have a lot of American Indians in Albuquerque, there are some meetings that are American Indian specific. And so we helped him to find some of those meetings. And we also talked with them about the different kinds of formats for meetings. That some meetings, a speaker meeting is pretty comfortable at the beginning for a person who's shy. A big book meeting or discussion meeting is much more uncomfortable because usually people then are asked to speak a little bit. And even saying I pass may be very uncomfortable for a client who's new to recovery, new to AA, and shy. So again, in looking at social environments, we're trying to look at a number of solutions that will help him connect up with more positive communities. Okay, in the last part of this talk, I'm going to show you a few of the techniques that we actually use to achieve some of the goals of the treatment. I do want to leave some time at the end for some questions and discussion, so as I say, I may kind of zip through some of these. So as I mentioned earlier, though, one of the important goals all the way through treatment is enhancing motivation, using a motivational interviewing style. We also sometimes give people very specific feedback about the extent and severity of their drink, at least with drinking. This doesn't work so well with other drugs. But we collect information about how much a person's been drinking and over how many hours, and usually can know a person's gender. And you have to know their weight to be able to figure out their blood alcohol level. For those of you who aren't familiar with the concept of a standard drink, it's really about a half an ounce of pure alcohol. So this is a simple little chart to show you what standard drinks are for different kinds of drinks, beer, wine, and hard liquor. This is not very helpful for this presentation, but it's a blood alcohol chart. It has separate sections for men and for women. It has number of drinks down the side. It has a person's weight across the top. And so you can figure out a person's blood alcohol level. So if Daniel had his 4-pack in an hour, and Daniel was he was actually a pretty big guy, so he weighed about 180. If he drank that right away, he'd get to a blood alcohol level of about 0.08. The one thing I want to point out to you here, though, is that for each hour of drinking, you subtract 0.015. So we don't want to do the math now, but if he drank those 4 drinks over 2 hours, we would subtract 0.015 from this. So his blood alcohol level would be actually 0.065. So this is something for you guys to fiddle around with if you're interested in it at another time, but I did want to show you the chart that is very useful. I usually give a person feedback. Sometimes I do it actually in a feedback sheet, and you feel free to use this feedback sheet if you would like. So we figure out how many drinks a person would drink in a week, and Daniel would start out, he was drinking about 100 drinks in a week. And then we would just calculate the number of days a person was drinking. He was drinking every day, so we just divide by 7. But you just give them, and sometimes people just don't realize how much they're actually drinking on a weekly basis. We then figure out the blood alcohol level based on the chart that I just showed you. And if they have a typical amount they drink, and they occasionally drink a lot more, you can figure out both of these. And then I like to give a person just feedback about some of the things they've been telling me about the negative parts of their drinking and the things that are most upsetting to them. And we just write some things down here. The value of the feedback sheet is that it gives a person a look at their drinking in a broader way. And sometimes it's very upsetting to people. Sometimes people say, yeah, I knew it was that bad. I always present it to a person by saying, the purpose of going over this is to really reinforce or support your plan, your decision to come to treatment and to change. You made a really good decision. And this is something you can look back on later on and see how much you've changed. Another technique we sometimes use is the decisional balance sheet. And some of these slides, the formatting has gotten messed up. I apologize for that. I don't know why. Must have been changing from one PowerPoint, mine to Kate's or something. But anyway, another thing that's often helpful to do with people is to just help them think about what's positive about their drinking or drug use and what's negative about it, and what's good and bad about abstinence. It's a way for them to kind of think through why they're trying to make these changes. Okay, changing triggers, dealing with those high-risk environments. We do a couple of things. One is helping them just identify what the high-risk environments are, partly by just talking, partly by questionnaires, and partly through what we call self-recording card. So this, again, is something you can use with clients if you would like. I give them a card for every day between treatment sessions, and I have asked them just to write down anytime they have an urge to drink, what time is it? Did it happen? How strong was it? Anything from just nothing to very strong. And then what was the trigger? What was the situation? I also have them write down if they do drink or use drugs, same thing. What time? What did they use? How much did they use? If it's not obvious how much alcohol was in it, so there's some beers that are really high alcohol content. Different tequilas, different rums, different vodkas have very different alcohol contents. And again, the trigger. The purpose of these is to help a person be able to become more cognizant and aware of what the triggers are that they're experiencing, so that they can be more prepared and figure out how they're going to deal with them. I also sometimes from the triggers, from the interviewing, if I use questionnaires, from the self-recording cards, we create a list. What are the biggest triggers for you? What are the hardest environments, the toughest situations with other people? What kinds of emotions and thoughts and feelings? So that we can begin to develop a plan, as I showed you with Daniel, for dealing with each of these kinds of situations. Okay, and then we try to help people develop plans to handle at least the environmental ones. So if you're in situations, physical situations that lead you to feel like drinking or using drugs, you've got some choices. You can avoid it completely, you can leave it, you can do something different in the environment by behaving differently, or you can rearrange it in some way. And sometimes we use a worksheet for this, what we call a self-management planning worksheet, where we write down a trigger, we come up with some ideas for a plan, And then we help the client write down some positive and negative consequences of their plan, and then help them pick out what they think is going to be the best plan. Okay, changing internal reactions is the next set of options that you have to work with a client. Two things here that I'm just going to talk about a little bit. One is coping with cravings and urges, and the second is changing thoughts about drinking or drug use. So there's some nice techniques. Sometimes people start talking about, all the good things about drinking or all the good things about drug use, and they get focused on that. And I try to help them develop ways of thinking about the negatives. Why is it that you wanted to change? Maybe we go back and we review that feedback sheet again. Maybe we do look at some of the behavior chains, and we say, okay, with Daniel, you end up with your mother feeling angry at you. You end up feeling very ashamed. You feel that you're wasting your life. How does that work in terms of you're thinking that alcohol is a good thing for you? And then helping a person actually think about, what do I do? What do I do to stop thinking negatively and start thinking positively? Some people find meditative or spiritual approaches or spiritual rituals really helpful in dealing with cravings and urges. And I'm not personally a person who's very good at teaching meditative techniques, but if these are something that seem to fit for a person, there are a lot of training tapes out there. There may be also very good communities to help people with using some of and becoming more effective in these kinds of techniques and approaches. One of the things I often like to do is in helping a person change their thoughts about drinking is to go back over that decisional matrix that I showed you. That was the pros and cons of drinking and the pros and cons of abstinence. And then have them write down some of these just on a little index card, and have them review that little index card several times a day. I've had people put it on Post-it. If they have a card, they'll put it on their dashboard, they'll put it on their mirror, they hang a card on the refrigerator, they put it in their wallet, they put it in their purse, they put it somewhere where they're going to run across it a lot of times in a day. And it helps them think about what some of those reasons are for them to change. And it sometimes helps when they're feeling tempted. So I want to double check with Kate. I don't see any questions up here, but Kate, are there questions that have come in so far?
We haven't had any questions yet, but please feel free to submit questions now, and then we will, we will have plenty of time to run through some here at the end. But yeah, submit them now, and then we can kind of, manage how we go about answering them. Okay.
Because as I mentioned early on, the part I'm in now is showing you some quick techniques. So if people do have questions about things they'd like you to address more directly, I'll go to the questions rather than this. But unless if I don't have questions, I'll just keep going with this. So feel free. Next part in terms of techniques is really learning new kinds of behaviors, and there are two different kinds that I want to talk about here. One is specifically how to refuse drinks or drugs, and the other is more general coping skills. So drink refusal is something that early on when we started trying to help clients learn how to refuse drinks, many therapists got very dogmatic about it and said, you have to do it this way. Over time, I've learned that each client and person they're trying to refuse drinks from is different. And so what I want to help clients do is learn how to say no in a way that's comfortable for them, it's respectful to the other person, and to offer an alternative. So if someone says, hey, you want to have a beer, saying no usually isn't that effective. It's like, no thanks, I'd really like a soda. If a person starts harassing or being really kind of pushy, then changing the subject works really well sometimes. But I think one of the things that's really important for clients is to understand that they should feel good about refusing drinks. They shouldn't feel guilty about it. They shouldn't feel that they're being disrespectful to another person. They're really being respectful to themselves. So I do see there's a question. Kate, you wanted to read the question?
Yeah, sorry, and this one was actually just a question about CEHs, so I don't think it's one we have to address to everyone right now. But actually,
Oh,
looks like another one just came in. This one is historical trauma can be different for Native Americans. Will this change the approach for changing their coping skills?
okay. That's a really good question, and I think an important one. I think, as I was saying at the beginning, at least in a CBT approach, what I want to understand with a person is the ways in which historical trauma is important to them, or ways in which it may be affecting them in the present. And so I think that it may change the kinds of coping skills that they're going to use. I'm sort of hesitating here because I think when we talk about changing cognitions, oftentimes, again, the stereotype is you should challenge your thought and say that it's wrong. But in a good CBT approach, to be able to say, I'm having these kinds of thoughts, and then finding ways to think about yourself in that, with those thoughts differently, is really important. So again, the content isn't as important as the idea of saying, let's think about thoughts, let's think about how you're coping in your world, and find ways that work for you that allow you to be more comfortable and perhaps more, be supported in not drinking. Sorry, it's a very short answer, but I did want to emphasize the idea of saying individual choices with each client about how you cope with this within this framework is really what's key. Okay, next question.
Yes. The next one is, do you spend time on educating the client on the physical effects of alcohol and drugs on the body or brain, or in the long-term and short-term consequences of that?
Absolutely. In a 45-minute webinar, it's sort of frustrating because there's so many things I want to say about the way I do treatment that I couldn't include. But I think it's really important for people to understand that alcohol and drugs are, that they do change your body and they do change your brain. I've had clients who've come into treatment who stopped drinking a few days before they came in, and I'd be evaluating them for withdrawal, and they'd say something like, "Well, yeah, I had the flu for a few days. I was sweating and shaky and vomiting," and they had no idea even that they were physically dependent on alcohol. So really, really important, I think, to do that kind of psychoeducation about the physical side of these substances. And also, people sometimes beat themselves up a lot that they can't just stop drinking or they can't just stop using drugs. And I think it's really helpful for clients to understand that their brains have changed. And I often will say kind of things like, your whole brain is adapted and used to having alcohol. And so you've taken it away, and lots of your nerve cells are saying, where's the alcohol? And they're kind of screaming out and they're getting angry about it. And so when you're feeling a craving, it's not, there may be a situation in the environment that gets that started, but your body is reacting differently and your brain is reacting differently. And then I also like to emphasize, though, that over time, your body will readapt and your brain will readapt. But this is not an easy process because it's not just I got to get out of the carpool, but it's like I've got to change my brain. So absolutely, it's an important part. Yeah, next question.
There is such a strong assumption at so many treatment centers and AA groups that people with substance use disorder lie or are in denial about their consumption or use. Having worked in the field, I do know this is often true, and that to view it as ambivalence is more useful. However, in assessing initial and ongoing behavior, how do you handle this?
Oh my goodness, that's a big question. First, people actually lie and minimize much less than I think that many clinicians believe. And I think part of it really has to do with creating a situation where a person feels comfortable with being honest. And so, for example, with those self-recording cards I use, I always say to people, if we've set a goal that you're not going to use, of course, that's the goal we want to achieve. But if you're having trouble and you're using, And you're coming into, and I'm seeing you as a therapist, and I think everything's going great. I'm not being useful to you at all. So I would much rather you be honest and, tell me what's going on. So, part of this, I think, is, creating the context for encouraging people to be honest. I think, though, it also, as a clinician, I know that people minimize to protect themselves emotionally. You don't really want to think about all the things you're doing when they're things that don't fit with your values. And it also, if you minimize or don't tell people exactly what's going on, you also avoid other people getting upset with you. So I think, thinking about this is in that context and just reinforcing, in a motivational interviewing framework, you listen for change talk or, verbalizations about the reasons that you want to change or, bad things that have happened or positive things you could see coming from changing your behavior. And so even as a CBT therapist, I listen for those same kinds of verbalizations and try to reinforce them. But it's true. People don't tell you the whole truth. And when you think about it, the whole process of therapy is kind of this odd thing. You come in to talk with a stranger, or you go to a group with a bunch of strangers, and we expect people to bare their souls. And it's really not what we do in normal life. And I think it's understandable that clients don't tell us everything, particularly early on, because they don't know us. They don't know how we're going to react.
Great. And Dr. McCready, do you have just a few more minutes? We can take those last few questions, or?
I have a conference call at quarter after the hour, so I have a few minutes. I can go over a little bit, which is fine.
Why don't we just do this next question, and then we will finish up here. Basically, do you consider the functional analysis as the backbone of CBT? Do you feel your cards are another form of homework and method to keep the client involved in their healing process?
Yes to both. Functional analysis definitely is the backbone. It gives me a guide for making sure I'm paying attention to multiple aspects of the client and their environment, and gives me a way to think about a treatment plan. And the self-recording cards, not everybody will do them. I have to say that, but I do pretty well with getting compliance because I look at them, and it's another form of having a person thinking every day about what am I doing, and helping them learn to be more mindful about their environment, as well as a way to have them do stuff in between sessions. Yeah.
Great. We do have a few more questions, Dr. McCready. I could send these questions to you and give you a chance to respond by email. That way, I could send your responses out to everyone who attended, if that works for you.
That would be fine. And I'll just mention that I'm flipping through the rest of the slides to make sure that you're aware there are a few more slides about different kinds of techniques. And my general summary at the end is it's a very useful model, but it has to be content specific to the client. Okay, so I'm happy to answer these other questions by email, and thank you all for participating.
Wonderful. Yeah, thank you so much, Dr. McCready, and for your wealth of knowledge that you shared with us today. I apologize for the little errors in your presentation, and I've corrected those, and we'll send the updated handout to everyone who attended. And then just a couple other reminders. You will be sent directly to our survey at the end of this webinar. So please give us your feedback. We love to know how this has helped you, or if it was effective in teaching you more. And then please remember our upcoming webinars, both in our behavioral health series for American Indian and Alaska Natives, and then also our essential substance abuse series. And again, I want to thank everyone for joining us, and thank you again, Dr. McCready.